Colleagues, thank you. We just formed a quorum. We can now call the meeting to order. This is the panel on health services. Thank you for coming. Item 1 on the agenda, information papers issued since the last meeting. Nothing special. And if there is no special comment, then let's move on to the next item. Items for discussion at the next meeting. The list of outstanding items for discussion. So we're going to have the next meeting in the middle of the the next regular meeting will be held on the 15th of December, and there are 3 items being proposed for discussion. 1. Retention of the 2 supernumerary directorate posts of the Electronic Health Record Office for 3 years. So this is just by way of seeking our endorsement for it to be submitted further to other committees. Next is legislative proposal to prohibit sex selection using reproductive technology. And 3rd, colorectal cancer screening pilot program. These are the suggestions from the administration. Any comments from members? Yes. Good afternoon, Bureau Director. So these 3 items are being proposed by the administration for discussion at our next regular meeting held on the 15th of December. Without further ado, we can now move on to item 3. Well, for the 2 items or issues on Ebola and dengue fever, they are pretty hot subject in town. That's why we're going to discuss the 2 infectious diseases together. So we'll have a joint discussion on the 2 infectious diseases. So let's wait till the Secretary is ready before he walks us through the papers. Thank you. Prevention of infectious diseases is a very important public health subject in recent years. We are faced with different infectious diseases, including Ebola and also dengue fever, and also the Middle East respiratory disease, or H1N9. And with regard to Ebola, we are very concerned about this, and the FHB and the CHP have been working closely, and we have also been holding interdepartmental and bureau meetings. And with regard to the emergency or alert program announced in August, we have put in place a series of preventive measures, and under the alert response level, we are now taking measures with regard to the immigration or importer point. Of course, we are all concerned about infectious or cases, imported cases, and we do not have direct flight with the affected countries. And as you might have noticed, with regard to Ebola, the incubation period might be somewhat longer, and therefore within 21 days, those without any symptoms might be traveling around the world, and that risk is there. That's why we have already got this temperature screening system in place. And on Ebola, well, while it's most infectious, that would be after the onset of symptoms, and sudden onset of fever is a very important characteristic or symptoms. That's why we've been carrying out temperature screening, and since August, for people coming from affected countries and travelers, we've been issuing alert to them, and we have also conducted initial screening. And in November, we started to issue the health questionnaire, so that I would be asking the travelers about their health conditions and so on. So we are going to extend that from the international airport to the road boundary crossings. That is starting from today. We will be doing that at the road or land checkpoint, and later on that would be extended to other BCPs on the road. And later on, other than the measures imposed on travelers from affected countries, we have emphasized that for countries with confirmed cases or close contacts of the infected persons, there will be travel control, so they would not be allowed to leave those countries. But then there should not be any general ban on travelers from those places. With regard to PPE, personal protective gear, we attach a lot of importance to that because if you look at the US and also Spain, there have been some local infection cases, and in the wake of that, we are very concerned about this, in particular for protective gear for health personnel and also whether or not training is adequate. The CHP has already discussed various measures, and we have also looked into use of different PPE and also the guidelines on the use of such gear. And on the whole, what we are using is in line with the CDC and also the WHO's requirements. We have also enhanced our stockpiling on these in order to ensure that there would be adequate protective gear. We have also we have also got hood and watertight protective gear. We have a 3 month stock in place, and also for PPE with regard to the putting on and also taking down, and also with regard to environmental hygiene, disinfection, and also with regard to the disinfection of cops and so on. With regard to those at the front line, and crash courses will be offered to ensure that they will be able to put on the protective gown in an appropriate manner, and every week they will also have to undergo retraining. So such work has been underway without any stop, and since the SARS outbreak, in conjunction with the mainland, we have already got this point-to-point notification mechanism, so that where such cases are identified, we would immediately alert our counterparts. With regard to dengue fever, we have already got 3 confirmed cases this year. As it's been 3 years since we last had a confirmed case, we have to attach more importance to that. It shows that we have already got Aedes albopictus carrying such virus, and there could also be linear infection. And therefore, if we are not able to eliminate such Aedes albopictus, it could also become an endemic. And we understand that many members of the public said that they are not too concerned about this, because if you look at the 2 local cases, the symptoms are not serious. But then there are 4 types. For the first infected case, the symptoms would be relatively mild, and also for the particular type, they will have immunity. But then for the other 3 types, they will not have any immunity. And if they get infected again with the other species, then there is a high chance that they will see symptoms onset, and it's a pretty serious disease, and it could be fatal. And therefore, we will have to eliminate mosquito breeding, and we will also have to prevent this. And in the wake of the cases with regard to Sha-Tin, Wang Tai-Shin, Qing-Yi, and where the patients live, and also for the 500 meters radius where the patients have been to, we have already conducted disinfection operations, and appropriate prosecution would also be taken against the persons. And also we have already stepped up our efforts in mosquito control, including hospitals, schools, and health talks have been organized, and also publicity materials have been disseminated. And also, with regard to mosquito control strategies, that will not stop. We will also be targeting places where they are of high concern. For example, standalone buildings, and also piers, and also loading and unloading areas at piers and so on, in order to step up our efforts in eliminating mosquitoes. And we have also got the Anti-Mosquito Steering Committee. It also had its first meeting last week, and we reviewed the relevant departments and bureaus' efforts in the light of the latest developments, so that amongst the departments there should be stepped up coordination. And on Wednesday last week, I also met with the 18 district councils representatives at a special meeting in order to enhance the surveillance role, and also to step up coordination and cooperation with the relevant departments. And in fact, after the meeting, the district councils have already activated many measures, and the FEHD has also been working closely to monitor the progress of such efforts. I understand that our members and the public are very concerned about Ebola and dengue fever. That's why all along we have tried our best to ensure that the information will be disseminated in a timely and adequate manner. Thank you.
Thank you, Secretary, 4 members have raised their hands. Dr. Helena Wong, Mr. Albert Chen, Mr. Albert Ho, and Mr. Chen. All right, 4 minutes first. Dr. Helena Wong. Thank you. My question relates to mosquito control measures. Well, members of the public won't know the kind of mosquito that has bitten him, and we would not just focus on Aedes albopictus. Well, in Kai-Tak, many residents have complained the following to me. It's about a primary student with lots of mosquito bites all over his body, from navel, tummy, and legs, hands, and everywhere. And then the lady, you can see her eye lid is all swollen. We have asked to meet FEHD staff, and we went to that housing development to discuss with the property management agency. The HD contracts out its management services to private contractor, and we're not sure whether their anti-mosquito measures are effective. Has FEHD went to see whether these measures are effective. I've also been to public housing estates to look for stagnant water, but the problem hasn't gone away yet. So what is the administration's plan? Inside PRH, it is not the work of FEHD. Can FEHD tell PMA and HD whether their measures are proper or not? We inspected a rooftop where stagnant water was seen, and then a bar of soap was thrown into the water because it's alkaline, and then it could kill mosquitoes. I've never heard of such a measure. So how will FHD enhance the effectiveness of anti-mosquito measures done by the community? Because if they are not doing it properly, you may have to help them or tell them. And what about places outside PRH estates? I think it should be the responsibility of FEHD in Kai-Tak. There are so many construction sites for building the Shatin Central Link, and further on there is Kai-Tak Nala. And the whole of Kai-Tak has not got any ovi traps. You can only see one ovi trap in the cruise terminal in Kai-Tak. I've asked how come ovi trap is not installed near the PRH estates, because population intake has started. There are a few tens of thousands of people living there, and I dare not wear short sleeves when I visit the place because I'm afraid of mosquito bites as well. FEHD, thank you, Chairman. Yes, FHD's daily work is mosquito control in public areas, and it also makes regular visits to PRH estates. Under the relevant legislation, property management agencies are also duty-bound to ensure that there is no rodents and mosquitoes, and they have to take necessary actions. We inspect these housing estates on a regular basis. We give them professional advice. And if we discover mosquitoes and other pests, we will prosecute the relevant party. We do not just give advice on mosquito control. When there are mosquitoes found in construction sites, we will prosecute the contractor as well. But you have not really answered Dr. Wong's question. First, whether these contractors are doing it properly. Have you got any prosecution records? Secondly, she's talking about the site at Kai-Tak, not ordinary construction sites. Now, if you do not answer the question adequately, we'll follow up in the Food Safety and Environmental Hygiene panel. Thank you. And our daily visits. No, I'm not talking about daily visits, but the two places. Have you ever inspected the places. I don't have the prosecution records with me now. What about the construction site in Kai Tak? All right. Please allow the department to answer. Dr. Ko. I think this happens in different districts. I met with representatives of all 18 district councils. Some district councillors mentioned black spots to me in particular. So I don't rule out the possibility of black spots. And if there are, please give us the locations and we'll follow up. Dr. Wong has just told you some black spots. All right, we'll follow up. Mr. Bachan. I'd like to talk about the dengue fever mosquitoes. Well, in rural areas, mosquitoes cannot be eliminated because septic tanks of small houses are hotbeds for breeding mosquitoes. Because people have not used any mosquito control measures at the ventilating chute, and as a result, in twilight, the mosquitoes just rush out. So, can FGHD advise small houses, actually for all the outlets of septic tanks, air outlets of septic tanks, you just add a screen and then mosquitoes will not come out, because if you go there late in the evening, you can see hundreds of mosquitoes swamping there. It's terrifying, and I think it is a simple measure to control mosquitoes. I live in a village, so I know that it happens frequently, and many residents have refused to put a filter at the gas outlet of their septic tank, and they do not just affect themselves but residents nearby. Now I'd like to talk about the Ebola virus. Some members of this council were so ignorant to say that there's the possible risk of Ebola virus spreading at occupied sites. They are ignorant and they are cold-blooded. They are using such remarks to press for political objectives. And I think, Secretary, you being a medical doctor, should refute such remarks. I'm concerned about this disease, EVD. Of course, if we have passengers flying directly from affected countries, the government would be alerted, but indirect arrivals are very difficult to cope with because of the long incubation period of EVD. As we all know, SARS spread to Hong Kong from the mainland, leading to 399 deaths in Hong Kong, and the whole community almost collapsed as a result. If we don't have proper communication with the mainland, I don't want this to happen again, because there are many Africans visiting the mainland, Guangzhou in particular. And the mainland has also got a lot of projects going on. They've undertaken a lot of projects in Africa. So there is frequent passenger flow. I'd like to know whether you can take random checks. It will be too late if you wait for a fever to develop. Do you have this rapid test? So when there is a positive result, you can take action. Please enhance sampling random checks at some ports so that you can identify possible patients earlier. Do you have such a way of testing patients? Dr. Ko, Mr. Albert Chen talked about finding somebody at our ports at random to conduct blood tests. I have not received any advice from WHO to do this. What we do is this. Well, for passengers from EVD affected countries because we can tell from their travel documents. And for other passengers, we'll use in-flight broadcasts to tell them that if they've been to these affected countries in the past 21 days, they have to fill out a questionnaire survey. We have started doing that. And for through train arrivals, for those coming from Guangzhou, most of them travel through trains, so we will extend this practice to Luowu border as well. Is it true that there is no rapid test for the virus? Whether you call it a rapid test is a separate issue, but when there is a suspected case, we will test. We will take a blood sample, and results can be available in 3 hours. Whether we can know at once by testing a blood sample at the border, I'm not aware of such a measure. Please see if there is an opportunity of checking at random. We will closely track technological development globally. If there are new techniques, we will certainly not ignore them. Mr. Champagne, I welcome the administration's decision to take some measures for arrivals by land. I know the passengers or arrivals have to fill out a declaration form, but it's on a voluntary basis. Will you make it mandatory? Most visitors to Hong Kong will live in hotels. If it is found, if a certain visitor is found to be problematic, is there any way you can trace them if the information provided is not genuine? And I'd like to talk about mosquitoes. Usually, in the summer, we have mosquito-related problems, but this time, the 3 cases happened in the dry season. Has there been any mutation of the virus so that the situation has been rather unexpected? Looking at the OVTRAP indices, they've been falling in recent months, but compare to the curve in 2010, the curve, the indices are on the low side. And we know that there was some tampering with OVTRAPs a few years ago. Now, you have a cover and with 2 holes left for mosquitoes to go into the OVTRAP. Has this has it been a deterrent for mosquitoes to lay eggs inside the OVTRAP, leading to lower indices? Dr. Ko, in the area of public health, there are many arguments for and against mandatory or voluntary arrangements, and they have their respective merits and demerits. When we have a disease which has a very strong stigmatization effect, if we adopt mandatory measures, the effect will be counterproductive. People will just try to hide their conditions. So we have no intention to make it mandatory. Through our broadcasts, we require visitors who have been to affected countries for the past 21 days to make a declaration. Or if they hold travel documents from these 4 places, you can call it mandatory, because as soon as they arrive, their identity is known, and we will invite them to go to another counter for processing. But for other people, they have to think for themselves whether they've been to these countries in the past 21 days. I'm sure they know, because it's a risky thing. So we are trying to strike a balance. Because any measure that is repulsive to possible patients will cause them to try to hide their conditions. we usually ask visitors to leave their mobile phone numbers because it's quite common nowadays.
Well, at present there are 4 serotypes of dengue fever, and this year, if you look at the OV trap indices when compared to past years, it's not particularly high. But then at different locations, if you look at our neighboring countries, the situation has become more serious, and at least we have already proven that there are 2 separate sources, and therefore, however low the OV trap indices might be, we have to insist on this eradication campaign. And how about the OV trap indices? Well, with your permission, Chairman, I'll ask Mr. Yun to deal with the 4th question. Thank you, Chairman. A few years back, we conducted a series of tests to see if we put in an additional cover what the result might be. With regard to the OV trap indices, there would not be any impact even with an additional cover. And during the rainy season, in different locations, the indices once went up to 10 or above. In some places, it could be as high as 30, 40. It's quite possible if the location has more Aedes albopictus. And therefore, with the additional cover on the OV trap, it would not affect the findings. We will still be able to get a correct indication as to the severity of the problem. Ms. Alice Mack, after the 3rd case, well, both the FEHD and the DFH have immediately gone down to Qingyi to carry out control measures. And recently, I've also been to a location where one of the patients live. With regard to anti-mosquito operation, you might have done that, but how about environmental hygiene or cleansing work? Well, in housing estates, I understand that they would be placing the refuse at the refuse collection point, and the cleanliness of the RCV or the RCP, and also what about the hygiene of the estate as a whole? Because after you have cleaned the place, there might once again be stagnant water. I've talked to the village representative. They said that you have done a remarkable job in eliminating mosquitoes, but then if you do not clean up the place so that the environment is improved, then how can you resolve this problem? Yes, we understand that it's not possible to achieve the effect of having no mosquito at all, but then it should not just be about mosquito control. We should also be cleaning up the place. And also on dengue fever, just now the Bureau Director told us that you've met with the 18 district councils and you've been doing something, but then at the community level, what additional publicity will you be doing? Because as far as we are aware, in Qingyi, not many residents are aware of mosquito control, and they are not really very worried about the dengue fever. So apparently they are thinking that this is none of my business. And many residents, if they travel to elsewhere in the summer, during the summer break, they have no idea that in Singapore, despite the fact that it's a very popular tourist destination, they would not think that it's highly risky when it comes to dengue fever. So would you be stepping up publicity in that regard? In particular, Malaysia and Singapore are high risk areas. Well, during our meeting with district councillors, some district councillors also suggested that at locations where there is stagnant water, we have to carry out more mosquito control operations, and we would also have to attach importance to environmental hygiene. But then we do not rule that there might be environmental black spots in different locations, and if we are aware of that, we have already told the district councils that they should provide feedback to us, in particular for the locations that the honourable member just referred to. We would also be looking into that. With regard to publicity, I'll refer to Dr. Leung, who will give us more information. That's from the Center for Health Protection. In fact, before the rainy season, in response to the request by the WHO, we have been working closely with a dozen or so such institutions, and we have stepped up publicity in different locations. And in the light of the local cases, we have been working closely with some community organizations. In particular, we have produced APIs, and also at housing estates. We would also be stepping up such publicity through the TV APIs. I think a couple of months ago you might have noticed that because at the time the director actually led a team to stage this public health campaign on mosquito-borne diseases. Well, that was rather effective, and of course these efforts must not stop, and people's memory tend to be rather short, so they might no longer pay attention to that after a while. That's why after meeting with the district councils, we are planning some new initiatives. For example, with regard to TV APIs, which you have been seeing or watching, and in recent months, if the response has become less enthusiastic, we might need to update that. And some even suggested that we may need to put up posters to publicize it, because we want to create this community-wide atmosphere that we will be working together to eliminate mosquitoes. In fact, every time when I attend public functions, I would be speaking about that. And if you have any new ideas, please let us know. Well, with regard to the hot tourist destinations, if they also have dengue fever, would you be providing the information to Hong Kong people as well? Well, for Port Health, well, in fact, we have been disseminating such information through our Port Health personnel. And if we have to target specifically a destination to publicize that there might be dengue fever, in fact, we have said about that on different occasions, because I've also come forward, and at least I've mentioned that Guangdong and Singapore are the two risky zones. But then we have got a list on our website. In fact, it's not possible for us to list out all of them. All you need to do is to browse our website. Mr. Albert Ho, with regard to dengue fever, Bureau Director, just now you told us that there are 3 local cases, and you're concerned that it might develop into an endemic. So for how much longer do you have to wait before you will come to a conclusion as to whether or not it has become an endemic? And once it has become an endemic, what follow-up measures will be taken to deal with the situation? That's the first question. Second, we have also noticed that according to the recommendation by the WHO, one of the important recommendations is that for countries affected by Ebola, there should be exit control in order to ensure that patients would not be leaving with the virus. And after the first case in Asia, have we taken special measures on that? And if yes, what are they? First, on the chance that it could develop into an endemic, what it means is that that particular disease would continue to spread in a particular location. And in Hong Kong, dengue fever would definitely not be treated as an endemic, because we would only have a local case once every few years. For imported cases, they would not be treated as local cases. And since 2010, in 2011, 2012, 2013, we have no case in Hong Kong. So for the time being, dengue fever would definitely not be classified as an endemic. But once the situation has developed to such an extent that every year, if we are going to have a certain number of local dengue fever cases, and if the number is not low, and of course internationally speaking, there is no standard as to whether or not you would classify that as a serious situation. But then if you have a certain number of cases every year, then definitely it has become a locally borne disease. And if you look at the Aedes albopictus in Hong Kong, is it true that many of them would carry the virus. And if you look at the two local cases, and if you look at the geographical location, they are very different, and they are from different sources. And if you look at the two types, or the serotypes, they are very different, and obviously they are from two different locations, and in those two locations obviously there are Aedes albopictus carrying the virus, and therefore the assumption is that you cannot just assume that it just happens in these two places. You have to assume that it also happens elsewhere in the different districts of Hong Kong. And if you do not step up your efforts in eliminating mosquito or carrying out a mosquito control campaign, then for the remaining Aedes albopictus, they will be able to pass it on to their future generations. And then next year, when we have the rainy season again, when mosquitoes breed very extensively, then there is a chance that we're going to have more local cases, and the chance would be high. And when you have more patients going around carrying the disease, then and if the local Aedes albopictus continue to bite these patients, for those who have already been admitted to hospitals, of course we will protect them so that they would not be bitten by mosquitoes again. But then for people walking around, and if they are bitten by local Aedes albopictus, then there will be more Aedes albopictus carrying the virus, and that would become deep-rooted in the local community, and that's why we would call it an endemic. With regard to export or exit control, if we only have one single case, and other than treating the patient and isolating him, then we will have to target this particular patient and his close contacts, so that all the close contacts will have to be identified and they will have to be isolated. That's the most appropriate way of dealing with the case. And if in a particular place, if the Ebola situation has already become one that is spreading in a community, then we must consider targeting the exporting country and impose certain measures on that. Yes, Mr. Poon Siu Ping, I think two colleagues have already asked issues that I'm concerned about. And well, for the three local cases of dengue fever, two happened in construction sites. In other words, two workers were bitten by mosquitoes while they were working, and they got infected. And I understand that the Labour Department will also be working closely with the CIC in order to step up their efforts to control mosquitoes. But then I'd like to know if the FEHD would be taking the initiatives to inspect these construction sites in order to reduce the problem. Yes, you will act on complaints, but then will you be taking proactive action by inspecting these sites? And for Ebola, well, I understand that the WHO is very concerned about this. I've also looked at the situation. I understand that there have been some interdepartmental drills since the 22nd of September. Apparently, there were two such drills since late September. So how many more will be conducted? And according to your plan, how many drills will be carried out? Thank you, Mr. Poon. Well, for dengue fever happening in construction sites, a simple answer to your question is definitely yes. We will take the initiative to inspect these construction sites. But then, is it possible for us to inspect all the construction sites around the territory? I dare not say so, but then we will be taking the initiative to inspect these sites. And as my colleagues have said, and if we are able to identify stagnant water, and after getting the water sample, and after we have caught Aedes or mosquitoes, finding out that there are mosquito breeding problems, then we will definitely be taking up prosecution action. In fact, in the wake of the two local cases, as you might have been aware, we have already approached the construction industry, and we have already appealed to them to step up their measures. We have already told them what they should be doing. So in case we have identified the sources for the two local cases, the management has already indicated to us that they have already stepped up their efforts in eliminating mosquitoes. Instead of doing that once a week, they would be doing this once or twice every day. So that's what's being done. As regards the drills that you refer to, I don't know if we have the figures with us. Well, the DFH might tell us more. Well, for the DFH, we have organized a total of 3 desktop drills and also on-site drills. We will be looking at a hostel or hotel environment and different settings. So we have conducted desktop drills, and I understand that the HA has also conducted a similar drill.
With the support of FSD in the transfer of patients between A&E department and hospitals, I believe the drills can be viewed from different perspectives. Mr. Pan, I observed a drill a few days ago that was a large-scale interdepartmental desktop exercise, and the FEHD and HA have carried out drills with their stakeholders and inside hospitals. We do not have any concrete figures for this small-scale drills. For instance, FEHD and FSD have carried out a drill in the transfer of patients. Perhaps Dr. Zhang, a representative of the HA, can supplement what's been done within HA. Or Dr. Ao, as said by the Secretary, in addition to large-scale interdepartmental drills in all A&E departments of HA, they have to carry out their own drills. It is also an interdepartmental one because it has to work with the FSD for transfer of patients by ambulances, so on and so forth. The first round of A&D drills has been completed, and led by doctors. There are also internal drills in hospitals to tackle a confirmed case, and different scenarios were formulated to carry out different types of drills. And then in late November, we'll have a second round of drills. We will cover interface issues with the FSD, and also the treatment of soiled medical waste, contaminated medical waste. It will be about proper disposal of such waste. It is also a risk control measure. Mr. Wang Kwok Heng, through you, Chairman, I'd like to ask the Secretary the monitoring of EVD. In an oral question in the Council, I asked a similar question of the Secretary. However, there wasn't enough time for us to carry out a thorough discussion. In Guangzhou, visitors from West African are given a mobile phone if they don't have any, and also a phone card, and visitors are required to turn on the mobile phones for 24 hours a day, and within 22 days, if they feel any discomfort, they should alert the relevant authorities. And 87 phones have already been distributed. Of course, some of them might already possess their own mobile phones. So you can see Guangzhou, our neighboring city, has adopted escalated preventive measures to tackle this disease. I asked the administration whether they would follow the practice of Guangzhou. Although the administration has asked these visitors to make declaration on a voluntary basis, still it is voluntary. Can the administration be more proactive? I note what the Secretary said. They would require such visitors to register the phone numbers if they have them. Of course, it is good, but for those who really do not have a mobile phone, will we follow the practice of Guangzhou? In particular, during the 21 incubation periods, you should have a rough idea of the whereabouts of such visitors so that you can track them, just in case they develop the disease in Hong Kong. You can take measures at source so that we will not have a repetition of the SARS outbreak in Hong Kong. We acted rather too late back then. Can the Secretary consider doing this? I have to repeat that different places may have different measures for controlling public health. I'm of the view that the measures adopted in Hong Kong are rather stringent. I don't see how doing what Mr. Wong suggested right now can enhance our ability to monitor the situation. Because after it is for the person himself to decide what to do. Even if you give him a mobile phone, he may choose not to switch it on. So I believe what we're doing now is appropriate. I don't think the enhanced measure proposed by Mr. Wong will significantly raise our ability to monitor the situation. Mr. Wong, well, if a person doesn't switch on his mobile phone in Guangzhou, he will be a wanted person. In Hong Kong, these measures are purely involuntary. You lost track of the persons. As I said, in the area of public health, the intensity of control measures is controversial, because if the control measures are too strong, are too weak, then it may not be effective. But if they're too strong, then in places including the U.S., some isolation measures have led to strong repercussions. So you have to strike a balance, and we believe we have struck the right one. If you are too high-handed, and if you tell them that you're going to track them, this may cause strong resistance. And whether the outcome is positive or negative, I'm not sure. I don't think this is going to help the effectiveness of our monitoring significantly. Dr. Kwokaki, regarding dengue fever, I'd like to know how well prepared are our hospitals, because I've seen reports that frontline medical healthcare personnel were not too confident of the kind of PPE available. You talk about Ebola, yes, EVD. Regarding PPE, protective gear, now you must have the strictest standard of PPE. Can you tell us the stock we have in Hong Kong? And secondly, regarding drills, you call this a desktop exercise. I think that involves a few members of the senior management sitting there to work out the response. But this may not be sufficient for healthcare workers, because in hospitals we do not have just doctors and nurses. There are other paramedics, and they may even be janitors having to port a patient around. Their training may not be sufficient. They are exposed to a highest risk, so to speak. So how can you ensure that they are sufficiently protected? And regarding the dengue fever cases in a construction site in Sai Poon, the second case was only reviewed at a quite late stage. Why is it so? Will there be remedial measures to ensure that similar cases in the future would not be exposed after 10 days. There are a few questions. The second question is about drills. The recent drill, which is a tabletop exercise, involves communications among more government departments. So, but for the remaining drills, they are certainly not tabletop exercise. For instance, the transfer of a patient from an A&E department to a hospital, will it be carried out in all hospitals? Yes. Accepting patients at A&E department, all hospitals are required to do a drill. And as for the donning of PPE and simulated scenario of a patient present for them to take care, well, there are actual drills. And Dr. Au from the HA can tell us how well prepared our doctors are. And Dr. Leung may take the third question. Thank you, Dr. Kwok, for your question. Regarding the preparedness of hospitals. Of course, we expect the first case to arrive at our A&E department first. So we also assume that our GOP, general outpatient clinics may also receive a case, and the third tier is our isolation wards. Because not so obvious cases may find their way into our wards, and then next year is our medical wards. Regarding PPE, we have a sufficient stockpile. We have tens of thousands of pieces of hood and also gowns and also shoes. People may think that they should be distributed a few sets back home. No, I think we're talking about proper training of dedicated teams in all hospitals. We have an ongoing communication with our staff. We've also got an intranet webpage to disseminate all relevant information, including the stock of PPE in all clusters to enhance transparency. This will help to address the communication gap that happened during the SARS outbreak. Dr. Kwok asked about the transfer of patients. Have frontline staff been given sufficient training? Thank you. First, I'll talk about no. You just addressed Dr. Kwok's question. Training. Yeah, training will certainly cover doctors, nurses, and all supporting staff. Supporting staff are among the top priority of our training. There are 3,000 of them. So all of them have been trained. Dr. Kwok, can you allow them to answer the question about construction sites? Why was the case announced so late? In one case, the construction worker did not have very obvious symptoms. He had a fever, but the other signs and symptoms were not very marked. His gait was rather weak. According to the clinician, it might be due to a chronic neurological disorder. So an investigation was done on all fronts, and the situation could not be explained properly. And then the date of onset was also not sure. Perhaps there was some memory confusion. So the symptoms were not obvious at first. As I said, most patients suffering from dengue fever have mild symptoms. Some of them might not even have consulted a doctor.
Yes, please press the button to speak. Sorry, Chairman, I was late. Well, if my question has been answered, please let me know. Yes, you have 4 minutes. I'd like to know a bit more. Well, I know that the administration has done some tabletop exercises, and that's what we have been told. But then what about at the community level? Because on the radio, I heard that the administration had been stepping up publicity on radio and TV. You explained what are the symptoms of Ebola, and also to avoid infection, you will have to clean and wash your hands frequently. But then in terms of publicity and promotion, you have not told us that in the event that you have a suspected case or patient, then what should be done about it. What I'm more concerned about is, well, earlier on, well, there was a suspected case near Chung Hing Mansion, and if there is a suspected case, then for the security guards and so on, well, they might also have wounds on their body, and yet they would still try to help the patient without putting on proper protective gear, and the ambulancemen have not arrived. So would the community be ready to deal with such a case whereby there might be community outbreaks? And also with regard to PPE, I understand that just now you heard that you have sufficient stockpile for frontline healthcare workers, but then do they know how to don and remove such gear? So do they have to undergo training as to how they are supposed to don such equipment? And also with regard to the notification mechanism between Hong Kong and the mainland, so will there be cross-boundary drills or exercises? First, on suspected cases, I think the message is clear. That is, if you have reason to suspect that there is an Ebola case, is a very serious situation, and therefore the first thing to do is to report the case and call an ambulance. And when you call an ambulance, and if you suspect that is an Ebola case, you will also have to make it clear to the personnel concerned, because during the early stage, if you call the ambulance center and if you have not specified that, then the ambulancemen would not have any idea that it's a suspected case of Ebola, and therefore they might not be prepared for that. But then if you have made that clear, then of course they would put on the protective gear before they come. With regard to places where there might be congregation of foreigners or people from the affected countries, and if they congregate in those places, or if there is a cluster or a number of guest houses within the same building, the FEHD and the CHP have been visiting those buildings, telling them what they should do, including how they can report the case to our ambulance people, and how they should put on the personal protective equipment, and also how they can disinfect the places. So some small drills have been carried out, and for me personally, in order to ensure that they have confidence in such work, actually earlier on there was a chance that I managed to meet some of the OC chairmen, and I managed to talk to them personally in order to ensure that they have confidence in doing that. And I've also told them that if they have any suspicion or difficulties, they should always contact us. With regard to the PPE, well, for the CHP, in particular for those who might come into contact with suspected cases, not only will we provide training, in fact we have been emphasizing that there should be repeated training, so that there would be training once in a while, and then we would also have to have people monitoring how they don and also remove the clothing. And with regard to our collaboration with the mainland, we have this notification mechanism, and whenever there are suspected cases, we would always notify the other party. Okay, many questions have been asked. Many members are concerned about Ebola and dengue fever, and also about the import screening and so on. So we hope that the Bureau will pay more attention to that. And also, Mr. Albert Chan also asked if a screen can be put on the septic tanks. So please consider that. Next item is about the expansion of the blood transfusion centers of the Hong Kong Red Cross. So while the officials are getting ready, Let's take a look at the paper.
因為呢一個議程咧係關於財務安排嘅，咁同時
This is about funding. This is about a funding proposal to be submitted by the administration. So, members, if you have any interest to declare, please do so while the officials are getting ready.
Okay, 咁我哋咧就係請有關官員咧就係。
Okay, let's invite the administration team to join us. This is about the blood transfusion service headquarters expansion or redevelopment. So it's about the BTS headquarters. So this is an item to seek our endorsement for it to be further submitted to the relevant panels, committees. So we have one more item for discussion. So Dr. Chen, if you don't mind, we don't have to brief members on the content of the paper. Let's go straight to the question and answer session. Yes, Mr. Chen Kin-po. Thank you, Chairman. Of course, I support the expansion of the BTS because we do have an increasing demand for laboratory tests and so on. And they said that the expected cost would be $890 million, and the tendering exercise has already started. Once we get the funding approval from the FC, then it's expected that the approval can be given in February next year, and then they aim to start the construction works in March 2015. But then we are now having this non-cooperation campaign at the FC, and everything will be affected because as long as the 3 landfills and 1 incinerator proposal is not approved, everything will be affected. And as this will take 4 years to complete, and also you expect that you'll be able to get funding approval in February next year. Are you being too optimistic? And what is the fallback plan in the event that the project will not be, in the event that this project is delayed? So how are you going to ensure that it will not be delayed? Dr. or Professor Chen, as we have stated in the paper, we expect to go to the PWSC and the FC for funding approval in February next year, and we hope to commence works as soon as possible. So that's the internal estimate. In general circumstances, and of course if there are external factors, then it will be difficult, if at all possible, for us to make such a forecast or projection. Of course, we hope that members will support us, and please also understand that whether it's the HA or the general public, this is a very important facility, and we've been waiting for that for a long time, because back in 1984 we built this center, and all along there has not been any expansion at all. Now that we have the expanded services and also new services, that's for the purpose of ensuring safety and quality of blood products in the blood transfusion service. So we are doing this solely for the purpose of enhancing our service quality, and we do not have any fallback plan at all. We hope that the proposal can be approved on schedule. And if we are not able to do that, then we can only queue up. So what would the implication be as far as the Hong Kong Red Cross is concerned? What if you have to wait for another year or so? And of course you will have to take it up with the filibustering members to hoping that they would allow it to be passed. Yes, Red Cross. Well, we are doing this in order to further enhance quality, and we are doing some redeployment work in order to ensure that our ability in testing and processing blood products can be enhanced. But then there is a limit as to how far we can go. That's why we hope that the expansion project can be approved as soon as possible. Yes, Dr. Kwok-Kaki. With regard to the BTS headquarters, I'd like to say that I support it, but then as we all know, we are all very concerned about livelihood issues, and it has nothing to do with the Bureau Director. Another Bureau Director is not willing to reshuffle the FC items. Well, without further ado, I'd like to go straight to the questions. With regard to blood transfusion service, we expect that our population will grow to 7.6 million, and well, it might take another 30 years before you can build another center. So with regard to the latest projection, so what's the population projection? Have you taken into account the size of the population in 30 years' time? And also with regard to the use of blood transfusion service, well, over the years there must have been some changes. I noticed that if you look at the latest service, we have the cord blood and also the cell laboratory testing. So with regard to the latest medical technology, I think you've been doing a lot of work with regard to the cord blood. Well, I understand that in some private institutions they are also doing the same. So to a certain extent, you will be providing the service to the parents who might have this need. And also for some parents, they are actually paying a very high fee for that. We might be talking about $20,000–$30,000. So would the administration be providing this service at cost so that for parents with some concerns, they would also be able to make use of this service? And also, how about bone marrow transplant? Would there be more facilities to support that? Well, I'll try to answer the first question, and then for the other two, I'll ask the HA to give you more details, because they also have this arrangement and they also have their own view on this. Well, according to our estimate, with the expansion, the facility should be able to cope with the demand for the next 15–20 years. And of course, other than the service load, the safety and also quality would also be enhanced. So my answer to your question is this: that is my projection. Why not 30 years then? Because it took 30 years for them to consider this expansion project. Why are you not projecting into the next 30 years? Well, I'll defer to Dr. Zhang, who will share with you our thinking. Well, our current estimate is to project into the next 20 years, but then can we also project into the next 30 years? But then I suspect that even if we try to do that, it might not be accurate, because in 10–20 years' time, the change in medical technology might be very different, and therefore, if we have to take into account medical technological development, it would be somewhat difficult. With regard to the cord blood bank, well, in private institutions, well, if you have to store the cord blood, well, if it's stored for the benefit of the baby, and if the baby has certain problems in later years, then that could be used again. But then that's not the purpose of collecting cord blood in our blood bank. We would like to ensure that for patients requiring stem cell transplant, in particular bone marrow transplant, everybody will be able to have access to this public cord blood bank for matching and for treatment. So we are not going to do what the private market is doing right now. Alright, a simple question. Alright, for the stem cell bank, if the bank is large enough, then would you be sending out this message for parents who are now spending huge sums of money on that they could also use the service? Well, after the expansion, with regard to the cord blood bank, we can have 10,000 samples, and if we can have 10,000 samples, then if you're suffering from leukemia or blood cancer, then the matching ability would be about 95% according to some experts. That should be adequate. I think that message is also very important. I hope that the HA can also disseminate that widely, because people don't have to spend so much money on that. But then what if they are not able to do so? Then we will have to ask Professor Casey Chen to do something about it. Well, if there is any delay to this project, then for the modernized equipment, because there are technologies available for use, and we may have to defer the use of it. But then for basic services, for blood transfusion, etc., we try to maintain the level of service, making use of existing technology and so on. You also talk about the implementation of new technologies and so on. Without additional space, we simply will not be able to do that. Okay, thank you. Any further questions from members or comments? Alright, this is about the funding arrangement. Is there any objection or difference in opinion by members? Do we object to this item being passed on to the FC or PWSC for consideration? You mean whether or not it should be placed on the agenda for the FC? I think for healthcare-related items, they should be given higher priority. I think members would absolutely want to pass this as soon as possible. So that's my comment. All right, thank you. Thank you for the officials for coming. Next item.
好，咁我哋係第5個議程嘅。
Item 5, Quality Management of Pathology Reports in Hospital Authority. Please invite the relevant officials to join us. Questions from members? If members are ready, can I give the floor to the Undersecretary to walk us through the paper? Thank you, Chairman. Yes, this is about quality management of pathology reports in hospital authority. In HA, there are 22 hospitals with pathology departments or laboratories providing pathological services. Pathological reports will set out histological findings and also the opinion of pathologists. And such reports are for clinicians one of the many tools for clinicians to make a diagnosis. The accuracy of a report can have a direct impact on the diagnosis of clinicians. HA takes the quality management of pathology reports seriously. The pathology service in HA is led by specialists who have to be accredited through a set of stringent requirements by the Hong Kong College of Pathologists and the Hong Kong Academy of Medicine. A full training program covers 6 years of post-internship training in recognized training institutes. And the training is divided into 2 phases, an initial phase of basic training followed by another phase of higher training. So there is stringent requirements and also accreditation. And at the hospital level, we have a mechanism to ensure the quality of pathological reports. All pathology laboratories in HA have been subject to regular assessment and surveys, and they are given independent assurance. And they also take part in independent assurance of operational standards and technical competence of HA laboratories to ensure that the reports are accurate. And the HA will carry out regular internal clinical audits. According to international standard, 1% of pathology reports are randomly selected for audit. As for high-risk or complex cases, all of them will be audited. And individual hospitals will also review and discuss the audit findings at their regular management meetings. At corporate level, HA has got a coordinating committee in pathology to establish clinical standards for quality assurance and identifies and manages risk inherent to the specialty. So there is a comprehensive and stringent system to ensure the quality of pathology reports. Well, there was a recent incident in United Christian Hospital. Perhaps I should give the floor to Dr. Au to give you the details. Thank you. Mr. Au, Director on Quality and Safety from HA. Yes, I would like to briefly explain to our members the recent incident in UCH. On the 7th of August 2014, United Christian Hospital, or UCH, reported a pathology report deviation incident to headquarters of HA. And 2,153 pathology reports were reviewed, which were all reports issued independently by the pathologist concerned. And it was known that 3 reports from the same pathologist had deviation. And so the department decided to review all the independent pathological reports done by the pathologist concerned. And then a preliminary report was given to the HA. Among the 2,153 pathological reports, 5.5% eventually were, or 128 cases were found to be in need of revisions. They were mainly textual in nature to more accurately reflect the picture, and also some require minor amendments. 17 or 6.8% of them had to have the treatment portfolio reviewed. Now, this was not done after the review was completed. Whenever a case was found to be in need of adjustment, the patient was called back for a follow-up consultation. So all 17 cases were handled, and 15 needed minor adjustments, and 2 required major changes in treatment plans. In any event, this is a rather unique and serious case. There was never such a scenario involving other pathologists. So an independent expert panel was set up by UCH with the president of the Hong Kong College of Pathologists, Dr. Zhang, and a member of the Quality Assurance Subcommittee of the Coordinating Committee in Pathology, Ms. Dr. Lee Kam Chung, the Service Director of Kowloon East Cluster, and also the Chief Manager, Dr. Chen Ho-ming, who is present today, responsible for patient safety and risk management in our headquarters, and also an HA member in the Coordinating Committee in Pathology. After all the cases were reviewed, it was agreed that all 17 cases requiring changes in treatment plan had action taken, and no other cases was identified for adjustment in treatment plans. And those inaccurate reports was that there was no false positive misdiagnosis. Rather, there was only cases where less serious diagnosis was given. And according to the survey, those cases did not involve hard-to-judge cases involving gray areas. Rather, they involve cases where even a basic training would be able to diagnose. So we believe it was about a lack of attentiveness on the part of the pathologist concerned, and some recommendations were made by the panel. Some involve notification. When such a serious matter is identified, there should be a clear reporting line, and there should be a system for more junior doctors and trainees to be given more coaching and training. And of course, communication between the hospital management and the department should be enhanced. So improvements have been introduced. For instance, one-on-one coaching and assistance to trainees, and also a mentorship scheme introduced, and also some crew resources management training to enhance earlier identification and to strengthen the incident reporting mechanism. The pathologist concerned is going through human resource procedures that will include whether there were personal reasons leading to that level of performance. So we will certainly learn the lessons in this incident and to prevent a further occurrence. Thank you. Any supplement from the Undersecretary? No, thank you. I open the floor to members for questions. 3 members. Dr. Kwok Kee first. Thank you. Thank you, Chairman. Of course, that was only an isolated incident, but I think there are still lessons to be learned. So for that is about training of newly qualified specialists. We know that this 3+3 system is independent, but work is more and more demanding. And clinicians have less contact with patients. In the past, you have to treat 100 patients before you can qualify to be specialist, but now it may only be 30, 40 patients. So even if a specialist is qualified, that doesn't mean that he can work entirely independently, and there is also not enough support. 1% of a random sampling are the same percentage regardless of your length of service. Well, for a newly qualified specialist, it should not be 1%. I think for the first 3 years of being qualified, perhaps there should be a high percentage of sampling check. And I don't know whether this 1% of reports being reviewed is reasonable. Now, I'm talking about histological findings, not all pathology things. But for histological observation, it is really human-oriented, and therefore patients suffering from blood cancer, well, the reports will all be sent to a Dr. Chen in QEH. I don't have to name him. How come there is not a sliding scale for the percentage of review? And, for example, there are some pathologies not frequent, not so common, such as tumor in the brain or blood tumor. Even a specialist may not come across such cases very frequently, and he needs further assistance. So for such cases, shouldn't there be a high percentage of review? So instead of one doctor, perhaps 2 doctors should be required to sign such a report. Although you have a mentorship scheme, I don't see how you can help newly qualified specialists in their first 4 or 5 years. I don't want to blame individual doctors, but if risk management is not well planned, then there will be a higher risk of error. I'll try to answer first if necessary. The colleagues can supplement. There's a 1% review within the HA. It is an international standard. But I must say that they do adopt a risk-based approach in doing that 1% sampling, and it is not on the basis of the doctors concerned, because a specialist should have received basic training in the relevant college. So theoretically speaking, a specialist should be able to work independently. So in the past, the risk assessment is on the basis of specimens. If such kinds of specimens are more risky, then there will be 100% audit.
我同意嘅。
Yes, I agree that there should be a tiered approach. That's a very good concept in terms of risk management. And my observation is that the current approach is with the deployment of tasks. So for a higher trainee, well, even for simple report, they can do so independently, but then for the more complicated cases, they would not be allowed to do so. And after they have already graduated in the specialist discipline, and of course for private practitioners, they will have to do so independently. But then as far as the department is concerned, well, for the more complicated cases, that would be the way how we deploy the cases. Yes, we do have this tiered concept, but then for the newly qualified graduates, there should be more cross-checking. So we do not want to call it random checking, because after all, this is an independent practitioner, and therefore there should be more peer review. So we'll go back and think about it. And also for individual hospitals, well, I don't know, well, we have Dr. Chen from the Prince of Wales Hospital here. Well, in some cases, they would also conduct 5% random checking. So should it be a target that you'd like to achieve, even if you may not be able to achieve it right away in terms of the random checking? Because if nothing requires cross-checking, then that would be okay. We may not be able to immediately jump from 1% to 5%. But then Dr. Kwok was referring to the sliding scale. Well, according to the Undersecretary, you said that it's a risk-based approach, and then for the high-risk cases, you would be looking at more such cases, and then for the low-risk cases, that would be done on a 1% basis. But then for a newly qualified specialist, you'll be checking more, and for the others, you'll be checking less. Well, we'll convey this back to the Central Committee to consider it. It's hard to say, because supposedly he has already got the qualification independently. Why are we saying that for those who have been qualified for only 1 year, there should be more random checking? But then I agree that you cannot assume that for a novice specialist with just 1 year qualification, he'll be treated on a par with his peer with 10 years experience. How about the privatization plan? Will it be effective? So Dr. Sin, what's your initial thinking? Because that's the new thinking. Yes, am I getting through? Well, for the privatization program, it means that well, during the training period for individual pathologists, all right, as far as this case is concerned, before she is able to prepare her own independent report, will there be a mechanism in which we will be able to pick up the difficulties encountered by the pathologists concerned, so that we can step up training? So we are not targeting a particular doctor, we will be targeting the junior doctors. So before they join the pathology department, while he is undergoing training, and after he has passed the medium-term exam, there would be a senior pathologist with more experience to guide him all along. So he would be like a mentor to this fellow trainee, so that he doesn't have to walk around without knowing where he should be going. So for the areas that he needs a stepped-up guiding or guidance, then the senior pathologist will be providing more guidance to him, so that he would be able to identify the problems in an early stage. So that's what we'll be doing. Well, please wait for another round. Miss Mac, in para 9 of the paper, you've already explained that this is the personal performance of the pathologist in question, and you said that under the existing human resource policy, you are taking relevant procedures against that pathologist in question. So you think that is the personal problem of the pathologist in question. So are you going to resolve the problem through your corporate human resource procedures? Will you be handing over this case to the medical council for an inquiry, because it has to do with the professionalism of the pathologist in question. And what about the general practice afterwards? So if you have similar incidents and if you have proven that the pathologist in question is underperforming, then how are you going to resolve that? Will you be solving that at the corporate level, or are you going to have the case heard by the medical council? So in the past, how many incidents have taken place involving doctors who might not have performed the duties, and in how many cases have you passed those cases on to the medical council for inquiries? Yes, Dr. Au. Well, with regard to the human resource procedures, that would also include whether or not the cases will have to be passed on to the medical council for investigation. If you look at past cases, well, my earlier job was also in the human resource department of the HAHO. Well, as far as I could recall, for every serious incident coming to the headquarters, we would always discuss whether or not the case should be handed over to the medical council for investigation. During the past 3 years, there was one case which I was involved when it was passed on to the medical council for investigation. Subsequently, they felt that there wasn't enough evidence. That's why they did not open a hearing on that. But then, as it's been reported in the media recently, does it mean that all the cases will be resolved internally without referring to the medical council? No, that's not true, because at least in one case during my 3 years term with the headquarters, we did consider that. And I've also talked to Dr. Leung Pak Yin, and we have also interviewed the doctor in question, and then we'll hear from the doctor in question, and we have also discussed on how we can step up the communication and notification mechanism. Well, we don't have the information with us today, but then can Dr. Au submit the information to us later? Because you said that, as you can recall, there was one case in your 3 years term with the HA headquarters. I understand that there must be more such incidents in the past 3 years. So was there any incident in which you have passed the case onto the medical council for inquiry? Because you're giving people the impression that you would just resolve the matter internally. So amongst those doctors, how vigilant are they, and are they aware of the severity of the problem? You said that even if there is a mentorship program, in this case, you said that there would be a mentor, but then earlier on at the Tseung Kwan O Hospital, there was a case under the mentorship scheme, and it's about inserting a tube into the stomach, but then it was wrongly inserted into the lung. And then 2 doctors also supervised the doctor, and they felt that it was not a problem at all, and then subsequently the patient died. So given the heavy workload in the HA and the hospital, I would suspect the effectiveness of this. So I would think that, well, professionally, we have to be sure that doctors working for the HA would be professional, and if they had any problems, they should also be subject to professional disciplinary inquiry as their counterparts in the private sector. Alright, we've been told that there was one case that he had come across. Well, as far as my memory serves me, we have also provided some figures to this council on other occasions, so we'll go back and check. But I'd also like to supplement. Well, sometimes for the denominator, you might have the impression that there might have been many medical incidents. There is no reason why there have been so few cases. But then if you're talking about gross personal misconduct, it's a very serious matter. So it's somewhat more serious than negligence cases. That's why within the HA, indeed, there might have been communication gaps in the work process. And therefore, we would not be treating that particular staff member as a scapegoat. So you will have to consider which is the starting point before a case would be referred to the medical council. I think that's something that we have to bear in mind. I think members would like to get the figures, and that would be provided by the HA. But then the HA, as the employer, you will have to find out if it involves the personal misconduct of a particular staff member and whether the case should be referred to the medical council for inquiry. But then if it's a personal misconduct, and the employer would also be disciplining him in accordance with the house rules. But then for all medical incidents, whether or not it's a systemic matter or personal matter, will all those cases be referred to the medical council? I don't think so, because the HA has two roles, and therefore we have to distinguish between the two, or else the public might have this misconception, thinking that if whenever there are medical incidents, they will have to report them to the medical council for inquiry, because the HA is actually wearing two hats. Mr. Albert Ho, as far as this case is concerned, as some members have called it, it's an isolated incident. I hope so. But then, within a particular period of time, if the pathologist or the doctor in question has committed so many mistakes and made wrong judgments, then it's really very rare and serious. I'm sure all would agree, and that's why it has given rise to a public outcry. But then, if you look at the investigation findings, apparently you said that it's a question of vigilance and concentration. So if that is the case, then I have to ask the following questions. Are you saying that this pathologist has committed the mistakes not because of his lack of experience, it's just because of the lack of vigilance on the part of the pathologist in question? And if it's a question of vigilance and also concentration, then it might have been a personal matter, because you're not focusing your attention on your job. You should have the necessary experience. You should have asked other people for advice. But then if you fail to do that, then it's a matter of your attitude. And if it's a matter of attitude, then it's a serious problem, because it's about human life here. That's why, if I look at it from another professional perspective, I think it's a very serious gross misconduct. So it's a gross misconduct on the part of the pathologist. I do not see why the case should not be passed on to the medical council for investigation. Yes, you say that there is a possibility that the environment might have rendered it impossible for him to focus his attention on this. He might not be sufficiently vigilant because of the workplace environment. Why is that so? Why is it so? That's because of the pressure of time, and also because of the heavy workload. But then the report is silent on this. Is it purely because of the individual's personal attitude, because of his or her life? He is not able to concentrate on his work. For example, he has a lot of family responsibilities and so on. So we have to find that out. We have to have a more detailed report. And also, as the investigation is conducted by the UCH itself, why is it not done by the HA headquarters? Why is it not done by doctors from another hospital? And thirdly, you said that after looking at the report, there were 118 revisions, and 17 have to be modified, and well, some have passed away, but then they have nothing to do with this. Well, this is according to the hospital itself. But then, as we are aware, well, it has its established stance. But have you notified the patients? Have you explained to them? And have you ruled out the possibility altogether? So, have you ruled out the possibility of the misjudgment resulting in some results that you might not have wanted to see, including the passing away of the patients concerned? First of all, your question is about the staff member concerned. On this occasion, if you look at the process of investigation by the HA, they noticed that for the problematic reports, they have nothing to do with the ability of the pathologist. They are not really very difficult cases. So they are of the view that that has to do with the performance of the pathologist, and the pathologist in question lacks the necessary vigilance. So that's what they have found from the reports prepared by the pathologist. So in other words, it's not because of a lack of experience and a lack of ability. That's what you have seen from the reports. Yes. And also in terms of the workload, the HA has also looked into this. First of all, they look at the workload of individual members of the ward. So there is no difference, and this pathologist is not has not been given a particularly heavy workload, and the performance and the workload compared to other hospitals will also be more or less the same. So it's not a question of workload. Third is about the independent expert panel. In fact, Dr. Au can tell us more. In fact, it's independent. Well, let me clarify. Under the HA system, it's not for the UCH to investigate into its own cases. It just activated the process. And in setting up the panel, including myself, we have to agree to the membership of the independent expert panel. So we have to constitute a panel with the approval by the HA headquarters. And on this occasion, Dr. Chiang from the Academy of Medicine, the College of Pathologists, has also chaired this, and also there were experienced teachers from Princess Margaret Hospital forming the core team, so including Dr. Michael Chen. He's also not from Kowloon East, so there are 3 pathologists forming this panel, so they are not from the same cluster. So we have members from the College of Pathologists in other hospitals, and they are taking this very seriously.
There was no assumption on the performance of the pathologist whatsoever. And the final judgment was even for simple specimens involving peptic ulcer, and the pathologist got it wrong. Regarding human resources proceedings, well, I cannot comment too much. So there will be follow-up. The Human Resources Department will certainly consider workload, the personal health, performance. I think all these will be taken into account. And I want to clarify that we have not ruled out the possibility of referring the case to the medical council. We have to wait until the whole case is completed. What about patients affected? We have informed each and every patient. And when there are major amendments to the adjustment to the treatment plans, we have also informed the patients. In August, when the incident was reviewed, we adopted an open disclosure method. We said that all reports will be published. So no patient will be kept in the dark. In UCH, well, all patients have been informed. So you've explained to all of them that if they want independent advice or seek legal advice, that is their decision. So far, there is no such case. Dr. Leung? There is only one representative from the government who is in the pathology field this afternoon. Looking at the statistics, this doctor concerned has seen over 2,000 cases. And there were 2 cases where major changes were required. That was the most serious cases, and there were no irreversible damage in these 2 cases. Am I correct? You said 17 cases require adjustment in treatment plans. Well, adjustment sounds rather vague. My concern is whether irreversible harm done to these patients. Is the answer no? No. So the answer is no. So the doctor saw 2,000 odd cases, but there were only 2 cases where major adjustment were required, and there was no irreversible harm done to patients. Perhaps the doctor's performance was not too bad, because if you ask me, if I treat 2,000 cases and I perform in this way, that is not too bad. So are your expectations too high? Are they realistic? You said as if the situation was very serious, but there was no irreversible damage to a single patient. And haven't you exaggerated? I don't believe that out of the 50,000 odd doctors serving the HA, they can perform better. Perhaps from a risk management point of view, the HA can supplement. Well, the focus is not whether one or two patients have suffered any damage. As I said, 118 cases among the 2,000 cases require revisions, some in a textual way and some in content. So the revision rate is rather abnormal. For a doctor that can write independent report, there won't be as many as 5.5% of the reports requiring revisions before they can be released. So the situation is worrying. And let's see if Dr. Chen has anything to add. And the independent expert panel was rather uneasy because some very obvious and easy to diagnose cases were not spotted. For instance, for peptic ulcer, there is the spiral. There was a special kind of bacteria, but the bacteria was not spotted. Of course, by prescribing the right medication, the condition can be treated. Still, this is a situation that warrants our concern. However, I don't want to judge here how serious the situation is, because I may be jumping into a premature conclusion. Dr. Ang, last year, just for comparison purpose, last year, a heart transplant in QMH, wrong transfusion of blood. There was one senior surgeon involved and one senior medical doctor involved. Was it more serious, a heart transplant and wrong blood transfusion? Which case is more serious? You talk about the level of alertness or vigilance and the consequences. If you compare the two cases, which one is more serious in your view? I think you can choose not to answer that question because you're not comparing apple to orange, apple to orange. I mean, apple to apple. Well, there are 2,500 odd reports, and after your review, 118 reports require revisions for whatever reasons, and that's 5.5%. And for 17 cases, only 17 cases were really serious. So is it really a very serious matter? Have I summed up properly? Dr. Liu, I think I've said the same to reporters. Looking at the statistics, I find it minor, 5.5%. Any single doctor who has written a report, if it is reviewed by another doctor, it is common that the letter would differ from the first in terms of wording used. So you write 100 reports. 5 of them, when viewed by another doctor, may come to a different opinion. So the objective fact is how much harm has been done. I think in all 2,000 odd cases, there was no irreversible damage to a single person. Is it really as serious as said? Dr. Au said for high H. pylori in peptic ulcer, it's very easy to spot, and the pathologist failed to see them. But I asked you, compare with the incident in QMH last year, which one was more serious? Perhaps you've been oversensitive. Well, perhaps it is not appropriate for the management to comment whether it's been oversensitive or not. However, only the first 3 cases was found, and then a full audit was done. No. Dr. Au, please answer my question. Identification of H. pylori. Well, there are still members on the queue, so please do not waste time. The question to the management is whether this 5.5% is making a fuss out of a minor matter. All right, 2 more members are waiting to ask questions in the second round. If you don't object, we will extend and end by 6:45. Mr. Chen Pan. Yes, I think the management should be more sensitive. A person suffering from malignant tumor, if he is diagnosed to be okay, what will you feel if you are a family of the patient, and if you are among the 5.5%, how will you feel? So you may call this case lucky or unlucky, but I think we should err on the safe side. In some hospitals, they take 5% of the samples for audit, and in some other hospitals 1%. So for this hospital, will it continue to take only 1% of the reports for random audit? And according to the paper, you have introduced a mentorship scheme. Do you have enough experienced doctors for implementation of the mentorship scheme? Must a report written by a junior doctor must be reviewed or read by a more senior doctor before the former can sign the report and have it released? Well, in UCH and other form of mechanism, I think they have proved to be effective. In a working meeting, it was found that a few reports were problematic, and so they decided to review the 2,000-odd reports. To a certain extent, the HA is of the view that this 1% random auditing is in line with international standards. For high-risk cases, all such reports will be audited. And other measure for risk management, well, they don't believe that by increasing the percentage of audit is not the main point. Rather, supervision of doctors can be enhanced. For instance, the pathology department has introduced a mentorship scheme, and there will be enhanced discussions between clinical departments. They would like to enhance training in this regard. Do you have enough experienced doctors to act as mentors? Dr. Au? Oh, as said by Dr. Sin in responding to Dr. Kwok's question. The mentorship scheme involves allocating a mentor to a junior or not so experienced doctor, so that there can be a continuous assessment of a doctor's performance. So if throughout the 6 years there are problems identified involving the ability and attitude of the doctor concerned, then action can be taken earlier and not wait until a later stage. Because in a department, there may not always be close contact between senior doctors and junior doctors, but with a mentorship scheme, there can be closer monitoring. Do you have enough doctors to do that so far as possible? Because there is a cap on the number of trainee doctors. Dr. Hannah Wong, I think this issue was raised by me because it is really a serious matter. Treatment plans are devised according to pathological reports. If a pathological report can go wrong, now it's as high as 5.5% in this case, this can lead to a wrong or ineffective treatment plan. Then it's not that we don't want to trust doctors, but it turns out that the doctor himself can be misled by a pathological report. So it is a serious matter. Can the HA tell us whether there will not be a repetition of such matters? And I'd like to know whether these measures will only be adopted in UCH or all hospitals in Hong Kong. Can you tell us whether all hospitals can ensure that there can be zero mistake for all pathological reports?
Is it possible to achieve zero mistake? And if you're not able to achieve zero, then can you make a pledge as to how far you can go? First of all, Dr. Wong, thank you for your concern. Well, in fact, in the incident in question, as we have repeatedly said, the question, number one, rests with the fact that this is an isolated individual incident and is about the personal performance of the pathologist in question, and there is a lapse of sustained vigilance in a task that requires a high level of attentiveness. That's why, well, other than the UCH, within the HA as a whole, with regard to laboratory, pathological laboratories, and also within the pathology department, with regard to investigation work that has been done already. As I just said, under the current mechanism, it has already done its job. That's why we have managed to identify the problem. So other than the UCH, well, at other hospitals, the HA will be doing this and targeting or looking at the UCH in particular. As this is a newly qualified specialist, that's why during the training period, we will have to step up coaching by senior doctors and supervision. That's why we have introduced this mentoring system. And on this occasion, we also look at the communication between the department and the management, how that can be expedited. And where such incidents occur again, we hope to step up or enhance the reporting mechanism. That's to target the existing situation. And if you're not able to achieve a zero mistake situation, so do you think 5.5% is acceptable? So for a qualified specialist who is empowered to make independent assessment or diagnosis, so would you find 5.5% acceptable? Well, as Dr. Au has said, and he can supplement, in fact, he believed that 5.5% was abnormally high. So it's not something that a qualified pathologist should have done. In other words, it should not be as high as 5.5% of his or her reports are requiring changes in treatment plans. Dr. Kwok. Well, just now, Dr. C talked about the mentoring system, and it's about training. But then if we look at the case, I think the focus is not on training. I think what we've been saying is about a clinical, clinical auditing. So to what extent should it be done? And you talk about the mentoring system. Can I ask a bit more about this program? Would you be providing further assistance to the newly qualified specialists so that they can receive more training and assistance in order to reduce the chance of making mistakes? And secondly, I've asked that many times, you have not got a positive response. That is about the 1% or 5% error rate for individual hospitals. Have you discussed that? Will you increase the target so that it would be less than 1%? So have you done that? And also for Kowloon East cluster and also the UCH, when compared to other clusters, if you look at past figures, they've got fewer resources. So I'd like to know the establishment. So when compared to other clusters, as far as the pathology department is concerned, is that the same or higher or lower? So can you give us the figures? I'll defer to Dr. Au first. on the mentoring scheme. Dr. Kwok would like to know more about the newly qualified specialists. Will they be given further assistance? Yes, I agree with the tiered risk management approach. But number one, are we able to change that from 5% to 1% right away? We haven't got any definitive decision. But then at the central level, we have got some preliminary discussion, and I believe Dr. Chen can share that with you. Dr. Chen? Yes, Chairman, members. First of all, I'd like to supplement on the 1% internal audit threshold. Well, the 1% internal audit is based on an international practice, and such international practice has been prepared by different institutions, including the College of American Pathologists and the National Association of Testing Authorities in Australia, and also the Hong Kong Accreditation Service. We have all adopted the same standard, and within the HA laboratory, that has also been we have also received external accreditation, and that's why we have adopted the 1% threshold. Why is it that in some hospitals they have adopted a higher audit rate? Well, there might have been some misunderstanding in the course of press reports. Basically, they are doing this 1% pathological auditing, but then we have already classified the samples or specimens into different categories. So for those that are undergoing frozen sectioning or renal biopsy and so on, they might be more complicated, requiring more specialty before they can be diagnosed. In those cases, there would be 100% auditing. And then as far as the other specimens are concerned, in most cases that would be up to 5%. So in fact, all hospitals are not just confining their auditing to 1% of the pathology reports. So for renal biopsy, so would that be audited in all hospitals? Well, for frozen section, so that applies to all hospitals. All HA hospitals would also have the 100% auditing, right? Yes. So how about UCH resource deployment? Do you have any information about that? Yes, Chairman, I can supplement on this. In fact, as far as UCH is concerned, in the pathology department, at the time there were 9 pathologists at the time when this happened, and now they have 10. And out of that, 7 was qualified, and now 8 are qualified as specialists. And if you look at the figures for last year, well, on average, every pathologist will have to deal with 250 to 300 reports. And if you look at the workload, well, the UCH is more or less has the same workload as the other hospitals. Can you also provide the figures for other clusters and also the average figure? Yes, we can. Dr. Leong Ka-lau. Undersecretary, there is a fallacy in your statement. You said that for the workload is more or less the same, and therefore it's not a question of heavy workload. But then, according to my understanding, well, for raw pathologists, they find their workload to be too heavy. So that's the overall situation. The situation is pretty serious. And for individual pathologists, if they had certain personal physical problems, and of course the problem might be more serious. And apparently your fallacy is that how come he can do it and you can't? I think the thing is the average workload is on the heavy side. That's the impression of the average pathologist. You're thinking that 300 cases per month, so you're talking about 15 cases a day. If there are 20 working days, is a bit on the high side, right? And also, by way of a comment, there's a senior doctor, Professor Lee Sam-ping, when he came here, and if you ask Michael Jordan to do this penalty shoot, and if you ask him to do it 100 times, of course there will be mis-shooting or mis-aiming. So how can we expect that there will be zero mistake committed by individual doctors? How can that be achieved? I would have thought that this might be somewhat unrealistic. So they always try to do their best. I think that's always correct. But then I think the HA should also manage the expectation on a more realistic basis. Yes, it's not a problem to expect the best, but then there are bound to be human errors. Well, when we do surgical operations, we have been saying that we should not be leaving any suture or sutures in the body, and then the nurses might be counting that time and again. Still, there are bound to be mistakes. So when the management deals with medical blunders and incidents, you also have to make sure that that would be within the reasonable expectation management, because doctors are, after all, humans, and under certain circumstances they are bound to make mistakes. Alright, we only have 5 minutes to go, so Mr. Ho, you go first, and then we'll ask them to reply. I think there are bound to be mistakes because I'm also a professional, but then some of these have to do with clinical judgment or diagnosis, and it involves different judgment. You may not be able to call it a mistake per se. I would not call it negligence, because when you make a judgment, sometimes it's not easy to come up with an accurate judgment with the benefit of hindsight. That's why, well, even if there is a mistake, it doesn't necessarily mean that you'll be able to convict a doctor, because it's a clinical judgment. It doesn't necessarily mean that there is negligence involved. So when do we call it a negligence? Because you are acting far below the generally expected standard. And we do not have an authoritative camp or school of thought which would support that approach, and then we would call it professional negligence. So by making a mistake itself does not necessarily mean that there would be negligence. And also, well, obviously if there is a mistake, for example, if you leave some suture in the body, and some of these should have been spotted, but then you failed to spot it, then that would be negligence. And some of these should have been spotted, and for any responsible professional, he would have told you that even if there is one case, it's one too many. And if I had done it, then I would have to be held responsible, and I would have to compensate. So I cannot say that, well, out of 1,000 cases I have done, well, I have never done it before, and I don't know why it happened to you. That's most unfortunate. And for the family who has been affected, of course, they would not agree with what you said, because they have had the misfortune of this happening to them. So my question is, let me take a look because I've forgotten my question. In any case, I'm of the view that the entire system should try to avoid any systemic risk as far as possible. As we just said, if the workload is too high or too heavy, then that might result in more human errors, and the chance of this happening might increase. I've forgotten my question, so never mind. Can you respond to that? I'd like to thank Dr. Leung and Mr. Ho for their comments. I believe that the HA would note your concerns. With regard to workload of doctors, as I've said, in this case in question, the HK's IEP, the Independent Expert Panel, has looked at the incident and also the problematic reports, and the conclusion is that it has nothing to do with the workload of the pathologist concerned. Mainly, it's about the nature of the mistakes that the pathologist has committed. And if you look at the actual workload, whether it's too heavy or not, well, I'm sure the HA and the relevant department would be monitoring that closely. Of course, they don't want to see a situation whereby the heavy workload would affect patient safety or the quality of care. So we only have about a minute or so to go. Anything else, Mr. Ho? It's a very short one. All right, for forensic pathological reports, because when we go to the coroner's report, we would argue about the forensic reports. So what about the auditing of such reports if it's about death inquiry or inquest? So would there be auditing of such reports? Are you aware of that? Well, maybe the department can help us, because it's about forensic pathology. We don't have anybody from that department, and very often those reports would be highly controversial, but then it's not under the subject of discussion today. All right, we have discussed the UCH incident, and apparently members are all concerned about the mentoring scheme, whether or not it's effective in helping the newly qualified specialists. And there has also been this debate about whether the auditing should be set at 1% or 5% of all the cases. Okay, item 6 on the agenda, AOB, we don't have any, and date of next meeting, 15th of December. Thank you.